Alrighty, let's go ahead and get started here. How was everyone's weekend? Good, I hope. A few things to talk about first. With your EALs, uh, please be sure that you log into a computer or a laptop at some point so that your grades can actually transfer over. There's a couple people who haven't accessed the EALs on a computer or laptop yet, so your name doesn't even um, pop up for a report for me to even get your grades for you. So you have to do that at least the first time so that you'll populate it and I can get the reports off of what your scores are. And if I need to, I can transfer them over. Chapter 11's EAL should have closed on Friday evening. Chapters 21 and or 20 and 21 are going to close out this Friday. So um, if you still got a ways to go on those, make sure that those are your priority EALs to be working on this week. Um, your quiz this week, there's 17 questions to the quiz, and 16 of those 17 questions are on chapter 20, your case planning. So be sure you review that chapter before you take your quiz. Does anybody have any questions or anything for me? I think you guys are going to be getting an email soon, either today or maybe tomorrow, regarding the the new mask policy and the mask mandate. Basically, what it's saying is that we are going to be going away from you having to wear a mask on July 12th. So that day, July 12th, when you come to campus, the only place you'll be required to wear a mask is in the lab and your eye protection. Anywhere else on campus will be voluntary. So, but expect that email to be coming either today or tomorrow. I know it's coming out soon. But let me make sure that I got nothing in the chat. Good. Okay. So, chapter 14, post anesthesia care unit is what PACU stands for. But most often you're going to hear it referred to as the recovery room. This is where patients go after surgery to kind of wake up from that anesthesia, things like that. They spend typically 45 minutes to an hour in recovery before either being discharged to go home or sent to the floor to stay overnight or on a 23-hour observation or something like that. Um, like I said, patients are taken to PACU after surgery. Um, all of your PACU staff, all your nurses in there, come from a critical care background, which means that they worked in an ICU, something like that. And that's one of the kind of the requirements for working in PACU. You have to have that critical care kind of experience because these patients, they're coming out from anesthesia. They're going to be, groggy and their respiratory systems may still be a little bit depressed and things like that from these anesthesia gases. So you have to be able to, watch them closely and pick up on those things that are um, those kind of early warning signs and things like that. So if you need to get a surgeon involved, you can. Um, of course, PACU is in the same department as the OR because so we're close in case something goes wrong, or that way we can also, it's also for kind of that efficiency of movement. We can get that patient over into PACU, get them recovering and everything, and then get back to our room quickly so we can turn it over for the next case. And sometimes PACU can also be an ambulatory recovery area as well. An ambulatory meaning, maybe these patients didn't get general anesthesia. maybe they just had like some local anesthesia or like a regional block or something for their arm or something like that, then those patients don't spend as much time in recovery, and they can also be discharged straight home from recovery. Usually the PACU is like this. It's just this huge room, and it's got a bunch of different bays that are separated by like curtain. And so then you can have those patients fit into each one of those kind of bays. It helps to be able to a little bit more efficient patient care, right? That nurse doesn't have to be by that patient's side for the entire time. They can, be up at the nurse's station, and then look out from that desk and be able to see all the patients. They obviously have patient care, supplies. They've got suction. They've got, monitoring equipment for vital signs. They have IV fluids and warmers. They have their own drug machine, the Pyxis machine, to go pull out medications if they need to. All that kind of. They're basically kind of a small hospital into themselves. And then they should also have an isolation room in case you have a patient who has to be in an isolation room, so they don't spread their infectious agents around to other patients in that same vicinity and stuff. The PACUs, we don't spend a whole lot of time in PACU as STs. We may help transport a patient over there. We may go over and help with kind of an emergency situation over in PACU, things like that. But typically, we're not spending a whole lot of time in there. So the way that things kind of work over there, they're procedures, right? There's an admission, right? Immediately after surgery, patient's being wheeled in. The circulating nurse from the room gives what's called a handover to the PACU nurse, right? They tell them about this patient, right? What kind of previous surgeries, things like that, right? Allergies, if they have any other medical issues, things like that, that the PACU nurse should be aware of. And then they'll tell them what surgery they had done and, what's, our surgical site, things like that. We made like a midline incision, we did an appendectomy, things like that, right? What kind of anesthesia they got? Was it by IV? Was it inhalation? Right? How much? Right? How long were they under anesthesia? All that's going to be documented in the chart. Estimated blood loss, the condition of the wound, if there's any drains, or if we put in a pacemaker, all that kind of stuff. If there's anything else that PACU nurse needs to be kind of aware of. The ASA score, remember that's anesthesia's score that they give you. They evaluate the mouth and all that. How easy or hard were they to intubate, things like that. Were there any surgical complications, right? Did you have to give blood back to the patient? Did did something happen to the patient in terms of like, did they have a cardiac arrest, or did we have to do compressions on them, something like that, right? And then letting the PACU nurse know where their family is at. Is their family in the waiting room? Did they go back to the patient's room? Things like that, as to help the PACU nurse know when it's time for that patient to leave PACU and either go to the floor or go home. They know where to go find the family members for that patient. This handover, sometimes you're going to also hear it as called a handoff. Right? You're delivering this patient. One nurse is taking this patient to another nurse, so that other nurse needs to be aware of all of these things because they're critical care. Right? We need to know about that blood loss, because if the patient has lost a significant enough blood and we didn't give them any replacement, then if the patient starts to show signs of something, then the nurse knows what to attribute that to. They're not having to diagnose and assess them and find out all this information just so that they can treat the patient. They already know this information, so they can just provide that treatment. Things that they look for, these patient assessments, right? This is what they're looking at this patient for. They're checking their respiratory system. Are they breathing? Right? What's their O2 sat look like on the monitor? They're checking for circulation. What's heart rate look like? Blood pressure. Right? Those are big keys to your circulation. They'll also check pulses at random places. They'll check, pulses in the wrist, pulses down in the feet, behind the knee, just to make sure that the blood is getting to the most far out places, to the most peripheral places of the body. They keep an eye on your core temperature, right? Because that's one of the things that they found out about patients for healing, right? Is keeping that normal temperature. That's why we put bear huggers and warm blankets and stuff on patients in the OR, is to try to keep that body temperature as close to normal as possible. Or they do the same thing in PACU, because you're trying to, that healing process has already begun. As soon as you cut that patient, healing has started. So you want it to keep going. They'll assess the patient's abdomen, make sure it's not distended. They'll listen for bowel sounds, right? Making sure that the bowel is moving, that you're getting that peristalsis back. Right? It's one of the requirements for you to even be able to be discharged from the hospital, is that you either have to defecate or pass gas, because that lets them know that your peristalsis is back online. You're not going to end up with that paralytic ileus, where your bowel is no longer moving stuff along. And then they're going to check your fluid and electrolyte. They may draw some labs and have them sent off to see, what it looks like. They're also going to assess many other things, on you, your skin tone and your capillary refill, things like that, that are going to give them all these clues as to how you're doing as a patient and what they can do to help. Right? Do we need to start, do we need to give some more IV fluids? Are they, severely dehydrated, or do they lose a lot of blood? Let's make sure that they've got these IV fluids go, so we can keep that blood pressure up while their body makes more blood. But other things, so this is like your body systems that they're looking at. Right? Respiratory, circulatory, temperature, your fluid balances, things like that. And then now they're going to be checking your pain level. Right? How much are you hurting? Are you hurting more than you should be? Are you hurting less than you should be? Right? These kinds of things coming into play. If you're hurting too much, okay, let's look at maybe getting you some pain medication. Well, first, they got to check to see how much pain medication you've already received, because they don't want to overdose you. How alert are you? And this is all these assessments are continuously going on the entire time that patient is in recovery or in PACU. Because your alertness from when you first wheel into PACU is probably very low. You just woke up from anesthesia. You're kind of in and out. You keep nodding off and waking back up and nodding, right? So as the hour goes on, your alertness should come more and more. You shouldn't be continuously passing out. After a while, all that stuff's worn off, and now you should be more awake, more alert. What's your level of calmness? Right? Are you all excited, like trying to fight and get up out of the bed? And no, I don't want to be here. Get away from me. You yelling, you agitated. Are you just asleep? Right? There could be another reason to why agitation is coming into play. Right? Are you in a lot of pain? Are you a smoker? Because you're going through some nicotine withdrawals. That may be why you're and you need to. You got to go. Right? You can't, but maybe they can talk to the doctor and get you like a nicotine patch, bring you back down. Right? Are you moving around? Right? Can you move your legs and your arms and stuff like that? Are your facial expressions appropriate to what's going on? If somebody just came to you and said, hey, I know we said we were going to try and save your foot, but we had to take it off, and the patient starts laughing, not really the most appropriate response to having lost your foot. Right? Things like that. Like I said, you're looking at blood pressure, heart rate, that's part of your circulation, right? Vocalization, can you speak? After certain surgeries, like thyroidectomies, they need to be very, very careful of the recurrent laryngeal nerve. If they accidentally cut it just on one side, you're going to have some hoarseness to your voice and to your throat. It's going to sound different. If they cut them both, then your vocal cords don't open and close. So when you it's like you really can't talk. You can't reverberate that sound anymore. So all things that are going into these assessments, right? Muscular response, that's part of that movement. Renal function, are you making urine? Looking at the surgical site, seeing if there's any signs, early signs of infection, things like that, right? Checking drains, catheters, making sure that there's, those are secure in there and there's no leakage around them and that they're draining properly and that the drainage that's coming out is what it's supposed to be. So if you have a catheter in the bladder and you start seeing red liquid pouring out into the bag, that's a bad sign. That means there's bleeding somewhere inside the bladder. That's something that you bring to a doctor's attention. If there seems to be a lot of bleeding or a lot of blood, accumulating in a drain or something like that. Maybe we didn't get all the bleeders, or maybe one of the clips or something came off, something like that. Now checking like neurological functions, they typically use the Glasgow coma scale, right? This is checking that level of consciousness. If you're unconscious, you're going to score very low on the coma scale because your eyes aren't opening. You're not responding to verbal commands. There is no verbalization of your pain. You are not orientated to anything because you cannot respond. So you'll score very low. But if you can open your eyes on command, if they tell you, hey, raise your right hand, you put your right hand up, put it down, right? If they pinch somewhere and say, hey, can you feel this? And you're, ow, right? Those are all correct, right? Are you orientated? And it's typically 4 things that they're looking for: to person, place, time, and situation. Do you know who you are? What's your name? Do you know person, place? Do you know where you are? Right? Or why you're here? Do you know what time it is or what day it is? Do you know what's going on? So that's what it means by orientated. Usually you'll see that it'll say like the patient is orientated times 4. It'll be like awake and alert, orientated times 4, which means they know what's going on. They know what's going on around them. They know who they are. They know why they're here. They know what day it is. They know who's president of the United States. Those kinds of things, right? The kind of general knowledge kind of questions, kind of just to get an understanding that, yes, that patient is awake. They know what's going on. You can have people who are awake, alert, and orientated times 3. They know who they are. They know what day it is. They know where they are, but they don't know why they're there. You can have somebody who alert and orientated times 2. They don't know who they are. And they don't know why they're there. They know where they're at and what day it is. Typically, if you don't know who you are, you You're probably not going to know what day it is too, but you can see how it can get, and it can be somebody who's had a head injury, or it could be someone of older age, right? Like we got dementia or uh, Alzheimer's or something like that. They don't remember. They don't have that same kind of cognitive function. Uh, so you get these orientated times two, times three, times one, times zero, those kinds of things. Those who are orientated times zero don't know who they are, where they are, why they're there, all that stuff is typically going to have a power of attorney with them, somebody who's making those medical decisions and stuff for them, because that person is not of sound mind. Physiological care, right? Sometimes when patients are waking up from this anesthesia and stuff like that, you know, you're asleep. You wake up, and the last thing you remember was being in pre-op. And now all of a sudden you're in this different room, and you've got, like tape and this gauze over you, and you're like, oh wow, the surgery's already done, or you're like, whoa, where am I? And sometimes that nurse needs to kind of reassure that patient, hey, it's okay, surgery's all done. You're just waking up. You're here in recovery. Everything's fine. Just relax. You're taking care of you. Blah, 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 that kind of stuff, just to kind of get them back into it. And you're trying to kind of, help them orientate where they're at, right? It depends on what the patient came in for, right? If it was something that was like suspected cancer or something like that, they may be asking a lot of questions about, what was the diagnosis or what it come back with, things like that. You're just going to refer them to the doctor. They may be a little bit emotional, crying, or nervous or things like that, right? And they may be, anxious, stuff, stuff of that nature. So it's you're basically just keeping an eye on the patient, and this can happen multiple times in the same recovery visit. The patient, when they first come in, they're asleep, kind of. They wake up like, oh, hi, where am I? Who are you? Oh, blah, 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 right? You kind of explain, and they're like, oh, okay, okay, good. And then they kind of nod off, and they wake back up, and they're like, and it all starts over again. They forgot again. Everything that they just asked you, they're going to ask you again, and you answer all those same questions. It'll probably happen, in that first 20 to 30 minutes. They may ask you like 5 to 10 times the same questions. Right? They'll kind of pop up again and be like, surgery's all done? And you're like, yeah, I just told you that like 3 times already. And they're like, oh. So I only speak of this through experience, my wife having had surgery done, and then being with her in PACU as she woke up. It was the same. It was probably the first 10 minutes. She asked me the same question about 15 times. And I would answer it. She would just go, oh, okay. Kind of, her eyes would shut for a second, and she'd pop back open and be like she was just waking up for the first time. She's like, I'm all done? Yes. Well, what'd they say? Okay, go back into it. So it's just you reassuring that patient, helping them regain that orientation, keeping an eye on them physiologically, watching that blood pressure, watching the heart rate, watching the O2 sat, things like that, making sure they're taking those deep breaths. Just make sure they're waking up and that everything's good. There's a saying in the OR, and it also extends to PACU. Boring is good. And the first few times, for the first couple of years you guys are in surgery, pretty much every surgery you're going to do is going to be this, kind of cool. Oh, that was cool, or this one was a little different than the ones I've done before. Blah blah blah, things like that. But over time, things aren't going to surprise you as much. Things aren't going to be as new, and you'll find that the most boring cases are the ones where there's nothing exciting happens. Right? You did the case like you were supposed to, and those are good. Boring is good. It means nothing bad happened. With pain is one of those it's almost like the sixth vital sign is what they, especially in recovery, is how they refer to it, because they are watching, your respirations, your heart rate, your blood pressure, your temperature, uh, your kind of that sense of feel, right? They're looking for that pain response. And they ask them, multiple times, are you having any pain or anything like that? Or on a scale of 1 to 10, 1 being the least, 10 being the most, how would you rate your pain? That kind of stuff. Typically, they don't want to ask the patients like yes or no questions when it comes to pain, uh, because it always leads to a follow-up question. If they do say that they're having pain, then you immediately have to ask them, well, how do you rate that? So they'll usually just ask them, how would you rate your pain on a scale of 1 to 10, 1 being least, 10 being most? And that way they can give, if the patient's like 1, usually it's about 1 through 4. If the patient's saying that they have a pain level of about 1 through 4, uh, the nurse isn't going to give you any more pain medication. Partly because pain meds will depress your breathing. If you're saying that your pain is anywhere from a 5 to an 8, then you're going to get some dose, probably, of pain medication to help bring that back down. But respiratory, right? Some potential complications is you could have an airway obstruction, right? Like a laryngospasm or something like that in PACU. Sometimes, and PACU nurses hate it when anesthesiologists do this, but they will bring patients over to the recovery room still intubated with the tube in, and then remove it when they're in the recovery room. Not the most ideal thing to do, because if there is a problem, you want that problem to happen in the OR, where you already have that patient on a table. You can take care of it right then, right there. Once you get them over into recovery and now something starts to happen, now everyone has to rush to that patient in recovery with all these other patients in there and stuff. So with aspiration, this is something that's coming up from the stomach and then going down into the trachea. Atelectasis, this is fluid collecting in the abdominal cavity. It's coming out of the tissues and just pooling, and what it's doing is it's causing internal pressure inside the abdominal cavity, and too much pressure in the abdominal cavity then puts pressure on the diaphragm, which then puts pressure on your respiratory system. Because every time you breathe out, your lungs will shrink down, your diaphragm pushes up, giving more space to the abdominal cavity, more fluid fills up, and now whenever you go to breathe in, your diaphragm will, extend out, right, giving less room to the abdominal cavity. But if there's a lot of pressure in there, the diaphragm can't push, so you can't take a deep breath. You could also end up with a pulmonary embolism. This is a blood clot that has found its way to the lung through the pulmonary artery, right, or in the pulmonary vein. If you get a blood clot in there, it blocks the ability for that blood to either get reoxygenated or to bring oxygenated blood to the heart. And if you can't, hello? And if you can't bring that blood back to the heart, now you're, hello? Okay. And now the heart isn't pumping blood to the body. Typically, respiratory complications are the most common life-threatening issue in PACU. Sometimes it has to do with overdosing the patient with pain meds, which is why it's even more important for us to accurately give our nurse the amount of local anesthesia we used, because that plays into what kinds and how much pain medication they can give to these patients in PACU. Some other complications from surgery, right? You can have cardiovascular complications, having abnormal heart rhythms. Typically happens to patients who have abnormal potassium or sodium lab values. Typically something that we look at in pre-op. If the patient is borderline or over or under on any of those values, then we may not even do the surgery at all, because of the fact that you can run into a complication in PACU. Hemorrhage, right? Bleeding, right? You thought you tied off or you thought you clipped something inside, and that clip or that tie broke or came loose or something like that. And now whatever you had clipped off or tied off is now bleeding inside. Typically the way that's going to present itself in recovery is that you'll see that hematoma start to form under the skin. It'll be deep red, swelling up, getting big, things like that. Hypothermia, right? That body temperature going down. That's why we put the bear huggers and a bunch of blankets, warm blankets and stuff on these patients to keep them from getting cold. Hang on just 1 second. Yes. This one. Okay. Well, she's the one that gave me all those tests with those answers, like, because she made copies of her like key, and they were all highlighted. No, we did it already. I was giving you, that's the one for my file. Yes, sir. Sorry about that, Mr. Ortiz. Okay. And then malignant hyperthermia. So this is it says, like it says here, it's a rare thing, but it's hereditary. So if there's somebody in your family, usually your immediate family, but it can be, kind of that extended family too. If there's anyone in your family that has ever had malignant hyperthermia, then they treat you as though you can potentially have it as well. So they're going to do things to the anesthesia machine. They're going to trade out the soda lime. That's those white little crystals, the little rocks in that container that'll turn purple as you get the expired or the exhaled anesthesia gases, because that's absorbing all of that stuff. And the reason we change that out is because malignant hyperthermia can be triggered by anesthetic gases and succinylcholine. Succinylcholine is typically your main trigger, but those isoflurane, sevoflurane, those inhaled anesthesia gases can also trigger a malignant hyperthermia. And then also remember, always, if there's a patient who is having a malignant hyperthermia event, dantrolene must be administered. Dantrolene is like the anti-succinylcholine. What happens is the dantrolene will go in and kick the succinylcholine out of those receptor sites and take over. It helps knock them out so that you don't have that muscle rigidity anymore. Your body temperature's not shooting up. It helps bring all that back down. See if it's got the other signs. The very first sign of malignant hyperthermia is that muscle rigidity. Maybe the jaw starts to clench, or the fists, the hands start to clench or something like that. And their muscles and everything get real tight. The way that we kind of see it up on the surgical field is that it becomes very difficult to retract. Sorry. Mr. Ortiz got back from lunch and now he's ready to do some work. So he doesn't care that I'm in lecture. But yes, some of those first signs of malignant hyperthermia is going to be that muscle rigidity. And the way that we see it up on the field is we're trying to retract, and now the patient's own muscles are fighting against us. Nausea and vomiting definitely can be a complication. Usually that nausea and vomiting comes from the general anesthesia. Whenever you've had general anesthesia, it kind of messes with your stomach and things like that. And having that tube down your throat that whole time, you've been stimulating your vagus nerve that whole time. I know. It's all from Mr. Ortiz. Like I said, he just got back from lunch, so I think he was ready to get some stuff done and wanted to talk to me. So, and then you have that alterations in consciousness, right? You constantly, waking up, passing out, waking up. Those things should be wearing off. If not, then we start looking at maybe this delirium. Something has happened with the anesthesia has kind of messed with this particular patient's their system, their brain, and things like that. They may start to mess with their cognitive abilities. They may not be able to sleep. They may not get up and move around, messing with their senses, sight and smell and hearing and things like that. Typically, it happens to those who are advanced in age, kind of the elderly. But these are all the things that that can kind of contribute to that. Typically, I want to go back to the nausea and vomiting. Anesthesia will give things to the patient as they're putting them to sleep that helps try to prevent this. We call it like the pre-op. It's like pre-op or post-op nausea and vomiting prevention is what we're trying to do. We'll give them like Zofran or Reglan, something like that. Something's going to be kind of an anti-nausea, anti-vomiting medication. Partly because if the patient's had any kind of surgery on their abdomen or on their throat or something like that, you don't want them vomiting. It's going to hurt real bad. I mean, you cut through those muscles and all that. And now you're trying to use those muscles to and throw up, and all that's going to tighten. It's just going to hurt that patient real bad. And you don't want to be busting open any sutures and things like that. So you want things to try and stay as calm as possible. Discharging, right? This is sending the patient home. There's certain criteria that goes in. The patient has to be obviously, awake and alert and orientated times 4, or at least what they were orientated before surgery. We need to get them back cognitively, or alert wise, back to the way they were before they went into surgery. We have to make sure that they're passing gas or having a bowel movement or something like that. Also, that they're urinating. We need to make sure that renal function is good, that the peristalsis has come back online, that they're awake, that they have somebody to take them home. Right? We're not letting that patient drive themselves home. There always has to be a ride, and it can't be a cab. It has to be somebody who they can, kind of give responsibility to. Are they going to a nursing home or an assisted living place or a rehab place? Right, all has to be taken into account. Who's coming to pick them up? Right? Things like that. There also has to be an education done. I don't want to assume that all of you have been to the ER at some point in your life, but for those who have, you remember when it's time to leave the ER, it's time for you to go home. They come in with all this whole folder of paperwork, talking to you about whatever it is that you came in for, and some of the treatments, and then this is the doctor you want to talk to, and this is who you can follow up with, all that kind of stuff. As this education for surgery, what we're going to be telling these patients is, how to take care of their surgical wound, right? No getting it wet, how to take care of their dressings, what to do in the case that they see, these signs of an infection or things like that, who they need to call and all that. So that's part of that education, who they need to talk to, where and when their follow-up appointment is with their surgeon, things like that. And then they got to document all that and make sure, yes, the patient did receive their medication. They did pass gas or have a bowel movement. They are making urine. They don't show any signs of infection or, obvious bleeding. Their vital signs have all looked good, things like that. They are free to go ahead and be discharged and sent home, or they're safe to. I don't want to say free to, because that sounds more like, we locked them up or something like that for the time they were having surgery. But and we do all this too is to kind of protect the hospital. To say, hey, look, this is the shape that this patient was in when they left here. So whatever happened to them when they got home, we're not responsible for. When they left here, they were good to go. And when they came back, and maybe they didn't follow the education that they were supposed to. They didn't follow all those post-op procedures and things like that. They took a shower and got their incision site wet. They didn't take a shower. They took their dressings off, and they haven't showered in over a week before they see their surgeon again, and they have a surgical site infection. Not the hospital's fault. But there's a physiological criteria. That's all the stuff I was talking about. Right? No hemorrhaging. They're awake and alert. All that kind of stuff. And then there's the psychosocial. Right? That's that. You have somebody at home to take care of you. Right? You have somebody to take you home. All that kind of stuff. Right? Somebody to watch over you, at least for tonight. Or at least for that first 24-hour period after anesthesia, because that's when, if something's going to happen, that's when it's going to happen. Patient education. So this is the nurse does this, because they tell them all the little things that they need to do, right? Who they need to talk to in case of this and that kind of stuff. And we understand, this is kind of true for all people. You tell somebody something, right? You're teaching somebody something. Like these, this education, this patient's education is about, keeping a surgical site clean and all that kind of stuff or whatever. You expect that person is only going to retain about 20% of what you said. And that's just a normal, without having had anesthesia and surgery and things like that. Right? So you can understand how maybe some of that anesthesia is going to even knock that percentage down even a little bit more. Like they only remember 10 to 15% of what you said. So all education all training or education given to the patient regarding their specific care is also given to them in written form as well, so that later on they don't have to try and think, oh, what did they say? They said that I could take my dressings off and take a shower, right? That I could clean this, or did they say not to do that? Oh, I don't remember. Well, it's looking like you've got some crusty blood around my incision site and things like that. I want to really clean that up, so I'm going to go ahead and take my dressings off. Well, if you have it in written, you don't have to try and remember it. You can go back to and look back over it. Right? And they should typically put like a nursing hotline number or something like that. So if you have any questions, you can call that number, and then they can give you those instructions again or clarify something, things like that. Some kind of unanticipated things that can happen in PACU. If the patient doesn't, get up to that alert stage, an orientated stage, if they're not making urine, if they're not passing gas or having a bowel movement or something like that, they may have to move you to a different unit. You're not going home. You're going to either the ICU or to the floor and be on what it's not a 24-hour observation. It's a 23-hour observation. The reason for that is that if you make it a 24-hour, then insurance-wise and for billing of insurance, that becomes a day of hospital stay if you've been in for 24 hours. If you leave at the 23-hour mark or before, then insurance doesn't charge for a day stay in the hospital, an overnight stay. So, but this is to find out what's going on, right? Why aren't you getting to that level of being able to be discharged? What's happening? Right? Why aren't your bowels coming back online? Is there bleeding happening somewhere? Things so that we can do further assessments as to finding out what's going on, and then treat those. There is also AMA, which is against medical advice. Remember, the patient has the right to leave anytime they want. It is their right. However, there's something that they got to sign called an AMA form that they understand by leaving now, they're basically denying any further medical attention at this time, and that they're absolving the hospital and the doctor who's taking care of them of any responsibility. That doctor and that hospital explained to that patient the potential for what could happen to them, bad or good, by leaving and not continuing in their treatment. And they made the choice to go ahead and leave anyway. And it's like, okay, the only time that we don't allow them to leave is if they show us that there's going to be potential harm to themselves or to someone else. But then, rather than us admitting them to the hospital, we're admitting them under like a 72-hour, what's called a Baker Act. It's like a psychological hold, basically, so they can get assessed by a psychologist and things like that to see if they need to be held even longer, if they're more of a harm to themselves or to the public. There's the only times we wouldn't let a patient just walk out. But then that patient, upon leaving the hospital, they have to sign a form saying that they do understand all the risks involved with just leaving. Death in the PACU. Right? Remember, it's a rare thing for there to be a death in the OR. Typically, if the patient's going to die, or there's like an impending, they're circling the drain, they're going down real fast, and we think they're going to die in the OR. We try to get them out of the OR and either to the PACU or to ICU whichever's closest, so that we don't have to do the paperwork for death in the OR. I know that sounds kind of horrible just because we don't want to do any paperwork, we take a dying patient and just go and dump them off somewhere else and let them deal with it. But part of it is we got to do another case in that room. We can't typically afford to have an operating room be occupied by a terminated patient waiting on like a coroner to show up and all this kind of stuff. We've got other surgeries that need to get done. We're going to need the room. So, yeah. Typically, what'll happen is they'll just if they know that patient's going to die, we're going to stop doing whatever surgical procedure we were doing and attempt to close that patient up, and then get them off and get them over into PACU or ICU and let them expire over there. But guess what? That's chapter 14, PACU. I think on Wednesday and Friday this week, we'll review again chapter 10, SPD, and go back through it a little bit slower this time, and really knock home those parameters and stuff, because a lot of your CST questions are about kind of your parameters and then how to deal with lumens and sterilizing things that have a lumen to them. So we'll spend some time on that. Anybody got any questions? As the slide suggests. Chapter 10 workbook, I believe you guys did that last term. That's correct. So just do chapter 14. Well, is that a salute, Marcellus? Where'd you get that emoji? Oh, wait. That's not. Yeah, I think that is. Oh, no, it's a hand plant to the face. I got you. Remember that your chapter 20 and 21 EALs are going to lock out this Friday. So if you need to be working on those, make those your priority for the EALs. Because once they're locked, they're locked. I can't do anything about it. What else? Pretty soon it's going to be July. July 5th is a holiday for the 4th of July. It's our observance. That's a Monday. July 6th, that Tuesday, so about 2 weeks from now, Vision will be here to do more immunizations and Hep B's and fit tests and all that for those people who need stuff. We're compiling our lists right now, but they're also going to do your drug test and flu shots that day. So be prepared for those. Come ready to urinate. There will be somebody who watches you go. Whether it be, for the females, it'll be one of the females, and for the males, the male, so that they know that it's your urine going into that cup. That's all. Flu shots are not mandatory, but if you don't want one, you have to fill out the declination form, so it can be in your file. Any questions on that? All right, everybody. Remember if you've already got a flu shot, then just bring the thing that shows it or whatever, so that they can, make a copy of it and put it in your file, or check you off that you've gotten it done. I forgot what I was going to say. If Okay, well, uh, no other questions? Turn up the pressure, that's right. That I don't know if you can get a flu shot the week after a COVID vaccine. That's something that we'll have to ask the vision people to see if that's I think because they come back again in August. So if you don't get your flu shot in July, you might be able to get it in August. Um, Today is July or July. Today's June 21st. There are only 9 more days to this month, and then you have July, August, September, October, and then it's clinical time. So when you're in lab, buckle down, be doing as many cases as possible, getting your rhythms down, your uh, your kind of your steps, and trying to figure out those steps that are same for no matter what surgery you're doing. Right? You have to drape the patient. You have to mark your incision site. You got to make that incision. Put in some local. You got to do a timeout. All of those are going to be same across the board. The only thing that's going to differ is whenever we're working on that exact thing that we're either taking out or repairing or whatever. So since you guys have 4 months left, pressure is going to get turned up a little bit. We're going to start scrubbing in. We're not going to wait for you to be completely done with everything and then standing there and waiting for us to wash our hands and come in. We're going to just be coming right to you. Right as soon as 20 minutes hits, boom, we're washing our hands. Okay? Even if your Mayo stand isn't ready, things like that, even if you haven't got all your medications and stuff, because all that stuff does happen in the real world. Right? There's people, something can happen in the middle of your setup that causes a contamination, and you got to redo the whole thing. You can be behind. It's to help you prioritize. Okay? Set up the things that need to be set up first. Right? Worry about the things that aren't going to come until later in the case, until later during your setup. So that even if the surgeon shows up a little bit early and you feel like you're behind, you're not really that far behind because you've been taking care of those first things first. You're already kind of ready. Okay? We'll practice on it. All right, you guys. I will see groups B and C tomorrow. Someone last week from group B or C decided that they were not going to fold one of the drapes, one of the laparotomy drapes, and decided they were going to ball it up and hide it underneath the blanket of the bed in the theory room. That drape is waiting for you to be folded. So, almost got away with it. Not quite. All right, you guys. I will see groups B and C tomorrow in the lab. Guaranteed I'm going to be here. I don't care what else is going on. All right. Enjoy the rest of your evening. Remember, your discussion boards are due tomorrow night, your initial post. Right. Oh, yes. One other thing. Sorry, Mr. Ortiz asked me to remind you guys about this. For each group, the questions that you have coming up for town hall, which is this Friday. Remember the online meeting, the town hall, ST town hall is this Friday. If you have a question, something you need answered or whatever, please try to get those into Ortiz before Friday so that he has time to kind of research and answer and give you the best answer that you deserve. All right. All right. We'll see you guys tomorrow.